Good afternoon and welcome to this session. I'm really proud of our students, and you must be proud as well. It's a very important day. It's not the end of a journey, but it's just the beginning of another journey. So we are here just to give you a degree just of medical doctor, which is only the beginning of your new story. Now, before we start, you know we are in a hospital, so please, I know your joy and your enthusiasm, but at the very end, please go out. Don't be too enthusiastic, okay? Until you get out of the hospital, and this is only because we have sick people already at the first floor of the building. So you will be physicians in a short time, and you are able to understand what I'm telling you. Okay? So without any further delay, I'm really glad to call the first candidate, Francesco Lo Diacono. Professor Illuminati, would you like to introduce his work?
Madam Chairman, ladies and gentlemen, in this study, the degree candidate went over the data of patients undergoing simultaneous coronary angiography, eventually followed by percutaneous intervention and endovascular aneurysmal repair, in order to evaluate the results and the efficacy and effectiveness of this very new treatment strategy. So I'm leaving to him the floor in order to report the essential data on the performance study. The floor is yours.
I would like to thank Professor Illuminati for the introduction, the President of the Commission, Professor Damati, and all the other members of the Commission. The purpose of this study was to evaluate safety and effectiveness of simultaneous percutaneous coronary intervention and endovascular aneurysm repair in patients presenting with significant coronary artery lesions and abdominal aortic aneurysm. From January 2021 to March 2023, 7 patients presenting with significant coronary artery lesions and abdominal aortic aneurysm underwent simultaneous treatment of the 2 serious pathological conditions. All patients were male with a mean age of 71.5 years. The rest of demographics and risk factors were superposable to those standard for atherosclerotic disease. Combined procedures was decided after multidisciplinary staff discussion and was reserved to patients with symptoms suggestive of an underlying coronary artery disease or patients that underwent preoperative coronary angio-CT scan revealing critical lesions, both with a known infrarenal aortic aneurysm. All patients underwent combined procedure under single antiplatelet therapy and statin treatment, began at least a week before. In cases of chronic kidney insufficiency or allergy to contrast medium, patients were prepared according to standard distributional protocol. Procedures were performed in the interventional cardiology suite, equipped for femoral artery cut down and percutaneous intervention under local anesthesia. Coronary angiography and percutaneous coronary intervention were performed first and were followed by changing of introducership in order to proceed for endovascular aneurysm repair. Proximal and distal landing zone were identified by means of intravascular ultrasound, showing the anatomical landmark of proximal and distal deployment of the endograft. All procedures were performed simultaneously. Femoral artery access was closed using per-closed proglide device. One case of a patient with peripheral artery disease, surgical exposure of the femoral artery and direct suturing with prolymph 0 was necessary due to uncontrolled bleeding. In case of extension to the hypogastric artery, excision was achieved using side branch device. All patients were postoperatively monitored with electrocardiogram, dosing of serotonin levels, and assessment of femoral artery puncture for 24 hours, and were discharged on postoperative day 2. Control angio-CT scan of the thoracoabdominal aorta were obtained 1 month after the procedure, with subsequent vascular and cardiological follow-up according to standard protocol. Proximal and distal deployment of the endograft was assessed using intravascular ultrasound, showing in this case the left renal vein and the lowest renal artery on the left, and common iliac artery bifurcation with hypogastric artery springs on the right. This is the sequence of a standard endograft deployment. Intravenous contrast medium was used only for compression control angiography at the end, showing correct exclusion of the aneurysm, patent renal artery, and distal outflow. The primary endpoints of the study included either failure of percutaneous coronary intervention or endovascular aneurysm repair, bleeding requiring conversion to open surgical procedure, failure of local anesthesia, incidence of postoperative myocardial infarction, and incidence of postoperative lower limb ischemia. The secondary endpoints included the overall length of the procedure, the fluoroscopy time, the average amount of contrast medium injected, and the overall length of the hospitalization. In all cases, there was no failure of either PCI or EVAR. The open control of the femoral artery for bleeding was required in 1 patient. There was no failure of local anesthesia and no incidence of either postoperative myocardial infarction or postoperative lower limb ischemia was observed in any patient. The length of the procedure was about 200 minutes. The fluoroscopy time was relatively short, about 42 minutes. The average amount of contrast medium injected was 35 milliliters. And the overall length of the hospitalization was less than 3 days. In conclusion, simultaneous percutaneous coronary intervention and endovascular aneurysm repair can be performed in a feasible and safe manner, allowing simultaneous treatment of these 2 pathological conditions with reduced hospital stay. These also help avoid potential complication of untreated disease in case of stage procedure. Thank you. Thank you very much.
Thank you, Francesca, for this interesting work. Are there any questions from the colleagues? Danilo, Professor Tom.
Michael, yes, first of all, thank you. Very good work. So you mentioned single antiplatelet therapy before treatment, 1 week before.
Yes.
Why you didn't mention dual antiplatelet therapy after? So were the patient discharged with dual antiplatelet since they were deployed in an intracoronary stent?
Thank you, Professor Tony, for your question. Yes, patients were discharged on dual antiplatelet therapy after the treatment and also anticoagulant therapy for a week.
Good, very good, thank you.
Now on with the next candidate, who is Melina Eleni Gianni. I'm honored to present you because
Thank you so much.
Dennis Pozzi had a problem and is not here with us today. Melina did a very nice work on lymphatic sparing endocyanin green guided varicocelectomy.
Yes.
In children and adolescents. And the question is intratesticular injection safe for the testes? I hope yes.
Okay. Dear members of the Commission, my name is Melina Baldugiani, and I'm honored to present my thesis to you today. I want to thank you for this opportunity to present my work, where under the guidance of Professor Cozzi, we investigated the safety of intratesticular injection in laparoscopic lymphatic sparing ICG-guided varicocelectomy in children and adolescents. So starting from the basis, a varicocele is an abnormal dilation of the pompiniform plexus within the spermatic cord, and this condition disrupts the venous drainage from the testicles, leading to varices of the pompiniform plexus, and this can lead, as you can see here, to heat and stress, which can have a negative effect on spermatogenesis. As far as pathophysiology is concerned, there are various theories that you can see here, with the prevailing one specifying that varicocele may increase the reflux of adrenal metabolite and also induce testicular hyperthermia and or hypoxia, and also disrupt the blood-testis barrier. So how do we diagnose varicocele in pediatric patients? Most of the time, patients are asymptomatic, but they can present with sensation of heaviness or swelling or pain in the scrotum. And on physical examination, we perform the Valsalva maneuver in order to detect the varicoceles, And additionally, we use Doppler ultrasound for classification and confirmation. So varicoceles present a challenge determining the optimal treatment approach, because there is a lot of multitude of interventions that are documented in the literature, ranging from simple monitoring to open surgery. And these interventions can broadly be categorized in open, endovascular, and laparoscopic procedures. Regardless of the type, the goal of these procedures is to occlude the testicular veins or pompiniform plexus in order to alleviate the symptoms of varicoceles. The laparoscopic Paloma method has become the preferred method because of its minimal invasive character. And while laparoscopic procedures for pediatric patients are generally, and especially for varicoceles, are generally considered safe and effective, they don't come without any complications. Immediate risks include port-side hematoma, infection, bleeding, and also anesthesia-related issues, but the long-term complications are the ones that warrant particular attention. One notable complication associated with traditional Paloma procedure is the increased incidence of post-operative hydrocele. This complication arises because the traditional Paloma procedure does not prioritize the preservation of lymphatic vessels. And in response to this issue, there are several lymphatic vessel sparing techniques that have been developed. One of them is the use of indocyanine green, ICG, in order to aid visualizing structures during laparoscopic varicocelectomy. And this enhances the surgical precision because it allows the surgeon to better identify and preserve lymphatic vessels and ultimately reduces the risk of complications. So, sorry. So coming to our study, the main objectives were to evaluate the safety and also any adverse effects of intratesticular injection of indocyanine green during laparoscopic lymphatic sparing varicocelectomy, both in children and adolescents, and also to conduct long-term follow-up and analyze indocyanine green's role in visualizing vascular structures during varicocelectomy to ensure a lymphatic sparing approach. As you can see here, 72 patients were enrolled and underwent laparoscopic left palomo varicocelectomy with indocyanine green fluorescence in a pediatric surgery unit within the span of 2.5 years. Only 11 patients were older than 17 years with a mean age of 14.5 years old. And the surgical indications included a high-grade varicocele and also symptoms like testicular pain and also discomfort in all patients. And there was also concomitant left testicular hypertrophy in about 30% of the patients. Preoperative workup included clinical examination and also testicular color Doppler in order to assess the degree of the varicocele and also measure the testicular volume. And also semen analysis was available preoperatively in only 5 out of the 72 patients that were older than 17 years, and so the astenospermia in 3 out of these 5 patients. So, more about the surgical technique that was used. The procedure was performed under general anesthesia, and a peritoneal window was created near the internal inguinal ring in order to access the dilated venous vessels of the spermatic funiculus. The indocyanine green solution of 5 milligrams per ml was diluted and injected directly to the left testis. And with near-infrared fluorescence mode activated, we were able to identify the lymphatic vessels within 30 seconds. These were spared by blunt dissection, separating them from the spermatic bundle, which was then cut and divided using the Palomo technique. Follow-up included clinical exams at 1, 6, and 12 months post-op, with testicular ultrasound at 12 months to check for varicocele and hydrocele persistence. And patients 17 and older also underwent sperm analysis at 12 months. And we also monitored testicular regrowth, adverse reactions to indocyanine green, and complications. As you can see here about our results, all surgeries were minimally invasive with no need of conversion to open surgery or any intraoperative complications. Intraoperative visualization of lymphatics by ICG indocyanine green near-infrared fluorescence was achieved in all cases. And lymphatic sparing occurred in almost 70% of the cases with a mean operative time of 26 minutes. No adverse reactions to ICG were reported, and the median follow-up was 23 months, and no testicular pain from injection was reported, but only 1 patient experienced a self-limited scrotal hematoma. And no post-operative hydroceles were reported as well. And on follow-up ultrasound, only a small vascular area and microcalcifications were noted at the injection site at 4.2% of the cases. which, as you can see here, this is the 5 to 8 millimeter hypogenic endovascular area with microcalcifications that was found in the left testis at the injection site, which was only in 3 out of the 72 patients, but the tumor markers were all normal in these 3 patients. So repeat ultrasounds after 6 months showed resolution in 2 out of these 3 patients within a year. To conclude, laparoscopic varicocelectomy utilizing the Palomo technique enhanced by fluorescence-guided indocyanine green reported excellent results with a low incidence of varicocele persistence and no post-operative hydrocele at all. This preliminary data also confirmed the long-term safety of intratesticular injection of indocyanine green with no significant test-specific or patient-specific risks. And while these findings are still in the preliminary stages, the prospect of virtually eliminating a once very prominent and prevalent complication is highly promising. Thank you so much for your time and attention.
Thank you very much.
Thank you so much. Thank you.
For this very interesting presentation, also very well presented. And if is anybody are there curious? I'm asking you a question. I'm a pathologist.
Sure.
You are dividing patients in those with 1, 2, 3, 4 lymphatic
Spared, yes.
The influence of, the time of diagnosis is important. I mean, if you have a very, very pronounced disease, does it affect the number of vessels spared, lymphatic, or it is independent?
I believe it does affect it. As you can see here, I will go back so you can see. Most of the patients, because most of the patients were high grade, had a high grade varicocele. Most of the patients had around 2 and 3 lymphatic spared, and only some patients that perhaps had a less severe case had 1 lymphatic spared, and maybe some very difficult cases had only. Sorry, I said the opposite. Some minimal cases maybe had 4, and some very difficult maybe only had 1.
But the number of lymphatic spared is not affecting the outcome of the patient. I mean, it's not significant.
Yeah, no, it's not significant.
Okay, thank you very much.
Thank you so much. Thank you.
The next candidate is Chiara Santellani. Professor Fabbrini. She did her thesis work under the supervision of Professor Fabbrini, who is going to introduce her.
Yes. Okay, Chiara has shown great interest in this particular condition, which is dystonia, which is a neurological condition and movement disorder still not well understood in its pathophysiology. So using advanced neurophysiological technique, Chiara tried to shed some light on this complex phenomenon. So Chiara, please explain this complex work.
Okay, so thank you, Professor, and good afternoon to all the Commission. So as the Professor said, the study I based my thesis on is a study on cerebral network alterations in patients with isolated cervical dystonia using TMS-EEG. So dystonia is a movement disorder characterized by these sustained or intermittent muscle contractions, determining abnormal postures, movements, or both, and very often is associated to a sequela of non-motor symptoms ranging from psychiatric disturbances to cognitive impairment to sleep disorders. The pathophysiology of dystonia was first explained as a basoganglia dysfunction, determining this co-contraction of agonist and antagonist muscles. But nowadays it has shifted towards a more complex network dysfunction, meaning alterations in the connectivity between different areas belonging to the same network. In particular, the motor symptoms have been associated with an alteration of the sensory motor network, presenting with loss of inhibition and maladaptive plasticity of the primary motor cortex, altered sensory motor integration, and reduced connectivity of the supplementary motor area, while the non-motor symptoms have been associated with with a dysfunction of the frontoparietal network, and more in particular, in the connectivity between the striatal limbic circuit and the left dorsolateral prefrontal cortex. Those network alterations have been studied mostly using functional MRI that, however, provides an indirect measure of cortical activity. It has poor temporal resolution and gives us no activation-related information. And there's also the need to identify target areas for therapeutic protocols of neuromodulation. So an alternative method that can be used instead of functional MRI that has a much higher temporal resolution in the order of milliseconds and can also activate and directly measure the cortical activity is the transcranial magnetic stimulation coupled with electroencephalography, where the TMS part is the ones that through a coil would generate a magnetic field, which will create a perpendicular electrical current, which will go to stimulate the targeted area and its associated network, whose electrical activity would then be registered by the EEG scalp electrodes. And by doing that, we're able to study the local specificity by looking at the TEPs, which are the TMS evoked potentials, and also to investigate the network dynamics after source reconstruction by looking at which areas of the network have been activated and when. So the aims of our study were to investigate changes in connectivity in the sensory motor network and frontoparietal network in patients with isolated cervical dystonia, and also to investigate possible correlations with the motor and non-motor symptoms. The target was to compare 25 patients with cervical dystonia with 25 controls. Each subject was assessed with clinical scales for both motor and non-motor symptoms. And then the experiment itself was based on the delivery of 100 TMS stimuli per area at the level of the left primary motor cortex and supplementary motor area to study the sensory motor network, and at the level of the left dorsolateral prefrontal cortex and inferior parietal lobule to study the frontoparietal network. And then the EEG, during this experiment, the electrical activity was registered by 64-channel EEG. And then during the analysis, the trial averages were calculated to obtain the TEPs that then were compared between groups as well as correlated with the clinical scores. So those are the preliminary results. We were able to compare 18 controls with 20 patients with cervical dystonia. On those graphs, we have on the x-axis the time, where time 0, the impulse was delivered, and on the y-axis, we have instead the TEP amplitude. In blue are the controls, in red, patient with cervical dystonia, and the third is the comparison. Below we have the topographic plots, where in red is a positive signal, in blue is a negative signal, and can give us an idea about the distribution. So when M1 was stimulated, we found that a significantly larger P30 component in patients with isolated cervical dystonia, with a frontocentral distribution that can be seen in the topo plots below. And we know that the P30 is a marker of cortical excitability. We also found a negative correlation between the M1 P30 amplitude and the disease duration, meaning the larger the amplitude, the shorter the disease duration. When stimulating the supplementary motor area, instead, we found no differences between groups, as well as no significant correlation with the clinical scores. And when stimulating the dorsolateral prefrontal cortex, which instead belongs to the frontoparietal network, instead results showed a significantly smaller P30 component in patients with cervical dystonia, with a fronto-anterior distribution, but we found no correlations with the clinical scores that we used. So to summarize the results, we have seen that the M1 TEP alterations show an increased amplitude of the P30 component, which is considered a marker of cortical excitability, thus suggesting an hyperexcitability of the sensory motor network in patients with isolated cervical dystonia, which is in line with the hypothesis of a cortical inhibition deficit that were suggested by previous studies. There was no change when stimulating the supplementary motor area, and instead, when stimulating the dorsolateral prefrontal cortex, we found a hypoexcitability of the frontoparietal network. There was also this negative correlation between the M1 P30 amplitude and the disease duration that could potentially be explained as a compensatory mechanism that is present at the beginning and then later disappears. However, this hypothesis doesn't fit well with a pathology that has no progressive course, such as dystonia. So an alternative hypothesis is the potential effect in time on cortical activity of the botulinum neurotoxin treatment that is very frequently used in patients with cervical dystonia. In conclusion, we can say that the TMS-EEG has revealed to be a suitable method for the study of cortical alterations in both motor and non-motor networks, paving the way to the study of network connectivity in isolated cervical dystonia. Of course, further studies are needed in order to better define the clinical meaning of our findings, but this one already highlights two cortical alterations that could potentially be used in therapeutic protocols of neuromodulation with repetitive transcranial magnetic stimulation aimed at modulating the M1 hyperexcitability and the OPFC hyperexcitability, and also to have an effect on both motor and non-motor symptoms. And so that's the end. Thank you for your attention.
Yeah, thank you for this interesting and complex work. It's amazing. The way you were, presenting this data, even reading, the names of the exam was difficult for me. So it's really, really congratulations. And this is I believe, an important study, although I'm not the best person to assess the importance. I have a very, very small question. How are you planning to test the effect of therapies on this? Are you running a protocol to use this tool as a test for therapy?
There was
the sensory and motor, because I don't know exactly about the therapy, but how are you going to use it? Do you have already protocol or?
No, not yet. That was the second objective of the study, meaning once the pathophysiological aspects were
The data are robust to suggest that this could be
yes, exactly. And the aim is indeed to use these, so the pathophysiological data to develop therapeutic protocols that nowadays do not exist because it's only treated.
Rest of Filiponi.
Yeah. Congratulations for this work. I have just a curiosity. And do you think it would be interesting to correlate your results with also functional MRI? Because I'm a radiologist, that's why I'm asking that.
Yes, basically, these results support the findings that were already proven on functional MRI. So this hyperexcitability of the sensory motor network and instead in hypoactivation of the frontoparietal network. But of course, the aim of this study was to be more sure, let's say, because it's more a direct way to directly activate and measure the cortical activity.
Thank you.
Any comments from Professor Nicoletti?
No, only enthusiastic approval.
Enthusiastic approval.
Yes.
Thank you. Thank you. We join your enthusiasm. Thank you. The next candidate is Tom Lavosky. Tom, he did his work under the supervision of Professor Nardecchia, who's going to introduce him.
Good afternoon. It's a great pleasure for me to introduce the work of Tom. The modern medicine has radically changed the natural history of phenylketonuria since there is the early diagnosis through newborn screening and early treatment, which is a dietary intervention. However, there is the outcome of patients suboptimal, and it's not explained from the normal metabolic control. So in this area where it is trying to find a biomarker of this clinical variability, there is the work of Tom, which will explain.
Thank you very much, Professor Nardecchia. I want to thank also the Commission and Professor Damati. As Professor Nardecchia said, phenylketonuria is very interesting disease to talk about medicine because it was one of the first, not the first metabolic genetic disease that could be treated, and it's kind of a miracle for the medicine because before we will talk about, they will grow up with the cognitive and neuropsychiatric deficiencies, but with the right diet, we can avoid it, So phenylketonuria is a metabolic autosomal recessive disorder in the phenylalanine hydroxylase enzyme. That is not the only enzyme that works to convert phenylalanine to tyrosine. And it leads to accumulation of phenylalanine in the body. And this accumulation is part of the effects, the negative effects in this disorder on the body. Although there are also the biogenic amines that we will talk in this research, that they have a crucial brain function like cognition, motion, mood, and so on. And in PKU, the metabolism of these amino biogenic amines is disrupted. We have a few possible mechanisms for the disruption, and it may contribute to the neurological psychiatric symptoms observed in these patients. The prevalence of this disease is in Europe, it's 1 to 10,000 live births. In the world, it's 1 to 24,000. In Italy, it's even higher. So we performed a cross-sectional study aimed to evaluate the peripheral levels of dopamine and serotonin metabolites, with the focusing also on the 3-orthomethyl-dopa and the serotonin metabolites in PKU patients as compared to healthy subjects. In the group of patients, we aim to check whether the alteration found in PKU patients were associated with the phenylalanine levels on the same day and the clinical picture of the patient, which means the neurological, the neuropsychiatric, and neurocognitive, which we checked it with the CBCL exam and the brief 2 exam. And we took 112 patients, males and females, which were confirmed by genetically exam the deficiency of the phenylalanine hydroxylase. And the control group were 60. The patients were divided to above 15 years and less than 15 years. Patients and control underwent the blood sampling in the morning during fasting condition to analyze the metabolites of the serotonin and the metabolite of the dopamine, the 3-orthomethyl-dopa, and also the plasma amino acids and prolactin levels were also examined in the same day. And also, as I said before, the neurological examination and neuropsychiatric evaluation were performed on all patients. And here we arrive to the results. So we see that in whole blood, the patients of PKU had lower levels of serotonin and dopamine metabolites as compared to the controls. Here we can see the correlation between the metabolites and the phenylalanine in 3 different matrices: in platelet-enriched plasma, in whole blood, and in plasma, which we can see the p-value, which is significant. And the correlation between the metabolites and the functional tests, which are the neuropsychiatric and neurocognitive examination, the brief 2 and the CBCL. Here also we can see the negative correlation between the 3-orthomethyl-dopa. With patients that had the tremor, they had more 3-orthomethyl-dopa, and also in patients that had psychiatric disturbance by the DSM-5. Here we can also see the prolactin. Prolactin, we know that it's negatively correlated to dopamine, so we also wanted to check it, and we have the positive correlation in this case. In conclusion, our study confirms the reduction of biogenic amines in PKU patients and highlights the potential of 3-OMD, the 3-orthomethyl-dopa, as a marker for clinical prognosis. Of course, further research needs to be fully understand the mechanism behind these alterations and to explore additional factors that may contribute to variability outcomes among PKU patients, as Professor Narodecchia said before. So in other conclusion of this study, this 3-OMD
we can use it as prognostic value or as therapeutic value, or we need to check it in further researches. And thank you.
Good job.
Thank you.
Very nice, interesting work. Are there any questions, Professor Nicoletti? No, you have to
I have to go to my
stay. Yes, you have to.
Okay.
This is your stuff.
Yeah, no, this is not a spontaneous question, I would say. Okay. Now, by the way, it's not a question, but a comment. I was talking to Francesca about this. There is a syndrome which is called Segawa syndrome, in which BH4 is not synthesized, and these little patients are treated with L-DOPA and 5-hydroxytryptophan for a long period of time. Now, for people working on Parkinson's disease, for example, Professor Fabrini is a real expert on this. This is one of the demonstrations that L-DOPA-induced dyskinesias are caused by the progressive degeneration of nigrostriatal fibers rather than L-DOPA itself. Because in these little patients, you never see fluctuations, you never see dyskinesias. So this drop of biogenic amines that you see here, this is quite relevant and important, not only for these little patients, but also in general.
Absolutely.
For our knowledge on Parkinson's disease and other disorders.
Absolutely.
Congratulations.
Thank you very much.
We can go on with the next candidate. Rashid Kashaf Wasfi. Hi. He did his work under the supervision of Professor Nicoletti. Please, Ferdinando.
Okay. Thank you very much. You are an excellent student and very nice and very polite person. So it has been great for me to work together with you. Enjoy the project. It's Neuromed Institute in Benafro. This is an institute convention with Sapienza University of Rome, and the director is Professor Luigi Frati, the scientific director of the institute. The study is on stress-related disorder and antidepressant treatment, the effect on perineuronal nets. Maybe, President, you are interested in perineuronal nets.
Of course.
Yeah, no, because you are expert in pathology and histology as well.
Yeah.
And perineuronal nets are condensed form of the extracellular matrix surrounding GABAergic interneurons. And now interneuron dysfunction is involved in psychiatric disorders, including depressive disorder and schizophrenia. So it would be great to listen to your talk. Please.
Good afternoon, everyone. Thank you, Professor Nicoletti, for your kind words. It was an honor to work with you. Thank you, Professor Donati, for being here. And thank you for Tatsitani for being here as well, because it's a good interaction of pharmacology and psychiatry. So the topic is regulation of extracellular matrix by antidepressants. First, we'll talk about depression and how it causes abnormalities in brain networks. Then I'll present our hypothesis on depression and perineural nets and the experiment that was done to test this hypothesis. And lastly, we'll talk about the results and the conclusions that we can draw from this experiment. So as we know, depression is a common psychiatric disorder. Currently, around 280 million to 300 million people suffer from it. It has been predicted by 2030, it will become the major disease burden globally. So there is need to find new pharmacological pathways for depression, for the treatment of depression. Neuroimaging studies have advanced our understanding of the pathophysiology of depression, shifting the focus from the classic monoamine deficiency hypothesis to alterations of brain networks. For us, what's interesting are the executive central network, default mode network, and salience network. Executive central network is associated with executive functions such as decision-making, whereas default mode network is associated in functions such as introspection. For us, what has these neuroimaging studies found is that there's an abnormal default mode network stability, but also much more important is that in depressed patients, individuals, the default mode network will not stays active even during executive functions. This will lead over time to extracellular executive central network diminishment. That being said, if we move from the level of the brain circuits to level of cell, we can find new pathways. Our hypothesis is these perineural nets, these are a form of brain extracellular matrix that are associated with interneurons, mainly polyarbutin positive interneurons, basket and chandelier cells of the layers 5 and 6 of the cerebral cortex. So our hypothesis is that could these perineural nets be possible canalization substrates for finding new pathways of pharmacological treatment of depression. To test this hypothesis, we had 3 antidepressants, fluoxetine, vortioxetine, and amitriptyline, and we treated mice that underwent chronic stress in a model called chronic restraint stress model. So in practice, what happened was that first adult male mice were exposed to restraint stress 2 hours a day. And starting from second week of this stress inducing, the mice were treated intraperitoneally either with saline or one of these antidepressants for 21 days. After this, the mice were sacrificed and their brains were evaluated by immunohistochemistry evaluation of the PNNs and the parvalbumin positive interneurons by labeling the PNNs with the lectin called Listeria floribunda agglutinin, and the interneurons were stained with parvalbumin antibodies. On top of this evaluation of brevican and neurocan, these are proteins that are expressed in the perineural nets, and other molecules were so neurocan and brevican were evaluated by immunoblotting, whereas the other molecules were monitored by real-time PCR. So let's see the results and see what conclusions we can draw from them. The first is that fluoxetine was surprisingly the only antidepressant in the somatosensory cortex of these chronic stressed mice that was able to significantly reduce the density of perineural nets. Whereas in the medial prefrontal cortex, the results were a bit different. All 3 antidepressants were effective in decreasing the density of perineural nets in these mice. What's also important, if you look at these both slides, that when the saline treated mice, so basically the chronic stress itself increases the density of perineural nets on both groups, in both mice. What's also interesting that fluoxetine and vortioxetine, but not amitriptyline, which is a tricyclic antidepressant, these 2 antidepressants reduced significantly the brevican levels in medial prefrontal cortex. But when it comes to neurocan levels, which is another chondroitin protein, is a molecule which is important in the stability of perineural nets, not stress and neither any of the antidepressants reduced or increased the levels of the perineural nets in the medial prefrontal cortex. Now, what conclusions we can draw? Like we saw in the slides 5 and 4, the chronic stress increased the density of perineural nets in these stressed mice. What's surprising, though, is that only fluoxetine reduce the density of these perineural nets in the somatosensory cortex, whereas all 3 antidepressants managed to reduce them in the medial prefrontal cortex. And also fluoxetine and vortioxetine, but again, not amitriptyline, managed to lower the brevican levels in medial prefrontal cortex. Therefore, we can say, or we can hypothesize that there can be a quality difference between these antidepressants. As we know, fluoxetine is the gold standard currently in the treatment of depression in children and adolescents. So we hypothesize that the exclusive effect of the drug on the perineural nets in the somatosensory cortex could correct the alterations in the somatosensory maps in these children. So this may influence responses to external environment during childhood and adolescence. And finally, our findings may disclose a novel component of the maladaptive neuronal plasticity leading to abnormal functional connectivity in depression. Thank you.
Thank you. This is very, very nice work. Just a question, did you use confocal microscopy to study, to perform the immunofluorescence studies?
Fluorescence microscopy was used.
Yeah. Okay.
Yes.
Okay. 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 So you perform double immunofluorescence, triple immunofluorescence stains on these small animals, because the images are really wonderful.
Yes, if you look at here, there were used two types of stains, the Listeria floribunda agglutinin, and then probably antibodies, which is the orange here. You can see it there. And these two type of main stains were used.
Very, very nice. Thank you. The next candidate is presented by Professor Nicoletti, Fabian Filipini.
Okay, great. We have a major breakthrough in the treatment for depression, which is psilocybin. Psilocybin is an active ingredient of magic mushrooms. And I remember that some students years ago, they went to Amsterdam, they were eating magic mushrooms, and they were walking in the street, and all the cars were against them. And finally, they went someplace in Amsterdam, so everything was all right at the very end. But by the way, quite surprisingly, in Australia, psilocybin has been approved for the treatment of depression, actually for patients with treatment-resistant depression. And Australia is a strange country because ecstasy and MDMA is also approved for post-traumatic stress disorder as well. So they have a regulatory agency which is very flexible as opposed to the other regulatory agency in the world. So Fabian was very interested in that, and he asked me to work on this, on psilocybin. His first question was, do you have any project running in the lab on psilocybin? And my answer was no, we are not studying on psilocybin. And what about the clinic? And then I answered, okay, if you want, you can make an exploratory analysis on all the studies on psilocybin published in the literature, but please don't be involved in meta-analysis because I'm unable to do a meta-analysis. I cannot help you with that. And obviously, he made a meta-analysis. And it was great. I admired him because a meta-analysis is very difficult. You need a lot of skills to do that. And he did meta-analysis so well that I only learn from him. So congratulations. It will be great to listen to your talk.
And it will be an interesting conference because we have a candidate from Australia, and yes, so I hope there will be debate. Please go ahead.
Thank you, Professor Nicoletti. I will sadly not talk about Australia in this speech, but as Catalan, I can provide on that. Thank you for my family for coming, and thank you for my friends for listening. So we will stay generally in the same realm as Ali was already, so we are still in the area of depression. Just to give you a bit more background information on it, about 7 to 8% of people in the world that are considered to have depression. There's a wide epidemiological difference between the North and the South. Italy is actually quite well. But for example, my home country, Germany, is very poor. We have an average of about 12. So generally, it's assumed that colder countries and more northern countries have a worse outcome. like Ali has already hinted at, the impact of depression is very severe. So currently it is thought, there's no official data on it yet, that depression is probably the most severe in impact economically of all the chronic diseases, because it has a dual effect. Because the patients suffer, so they take treatment, but also they stay absent from work, and they also burden their social circles. So there's like a triple effect of things that lower the economic impact. At the same time, currently, suicide caused by depression is the main cause of death in people between 15 and 30. So obviously there's a huge epidemic, like pandemic issue of depression. At the same time, the treatment options are poor. So we have the classic antidepressants, which are SSRIs, SNRIs, and similar. They're all based on the monoamine theory, that if you just raise certain neurotransmitters like serotonin, dopamine, it will improve depression. The thing is, depending on who you ask and depending on which meta-analysis you look at, they will have different outcomes of how efficient they actually are, with some even saying they don't have any effect. But in general, the consensus is that they are not able to hold on. That pandemic is currently ongoing. So people have been trying to look for alternatives ever since, for example, also TMS, but also psychedelic therapy. There was a big hype around psychedelic therapy in the 70s, in the so-called psychedelic craze, which came together, and also a general societal issue towards psychedelics. There were many studies into it, but then it pretty much stopped for 40 years because of change in societal attitudes, and also because the SSRIs and the SNRIs became so dominant in the psychiatric field that they kind of replaced every alternative. So what is psilocybin? Psilocybin is a psychedelic, but actually it's a psychoplastogen because it has a dual effect. So like Professor Nicoletti has said, it comes from the magic mushroom, which is actually called the psilocybin mushroom. Psilocybin itself is a prodrug, so it must be ingested, and then it must undergo dephosphorylation by alkaline phosphatase in the stomach and form the actual active component, which is psilocin. Psilocin is structurally almost identical to serotonin, which makes it able to bind almost all monoamine receptors, and it has a dual effect. So we have a acute psychedelic effect, which is the one that most people who use it recreationally seek it out for, which is mostly because it acts on the serotonin receptors, the most important one being 5-HT2C and 5-HT2A, which it shares with, for example, LSD also. But what we are most interested in is actually neuroplastic effects. So psilocybin is known to rapidly cause the change in synaptic activity, especially in the hippocampus and the temporal lobes. So the synapses form new and reform very rapidly, much more rapidly than they would normally do. And the special thing about psilocybin is that it does that even after a single administration. So a single psilocybin session is enough to induce this change. So for my meta-analysis, I followed this scheme, which you probably know, it's called the Prisma chart. So you go on the most commonly used websites, which are PubMed, PsycInfo, Embase, Medline, and Central, and look for the most important keywords considering psilocybin and depression, which resulted in about 1,334 found studies, which I had to cut down to the 7 studies that you found down here. The inclusion and exclusion criteria that I used is most importantly, of course, everyone who participated in these studies had to suffer from major depressive disorder, which is a diagnosis taken from DSM-5. So there's different diagnostic manuals for psychiatry, but the one that I used for this one is the DSM-5. Every patient must be free of comorbidities that are psychotic or bipolar. They could have anxiety disorders, but only those. Every study must have been randomized, placebo-controlled, no open trials, no case studies, nothing else. And also the patients could not receive any interventional psychiatric treatment, so not TMS and also no ECTs. And the last thing is I had to make sure that everything was recorded in standardized scales. So the most important one being the Hamilton Depression Scale. If they used a different scale, I could convert it into the Hamilton Depression Scale. But if they used a scale that was completely made in-house, I couldn't convert it, so I had to recruit them. So I was left with 7 studies, which you can see here. The first meta-analysis I performed was I was pooling for the absolute reduction in Hamilton Depression Scale severity. So basically, how much was the actual total score reduced? And what you can see here is that every single study except one, which is Griffith et al. B, produced a significant reduction in severity on the Hamilton Depression Scale. The reason why Griffith et al. B didn't is because B is the follow-up to A. So the patients already received psilocybin beforehand, so it kind of makes sense that they would not have as strong of an effect again. The overall standardized mean difference that I pooled was minus 2.22, which in layman's terms means that on average, the reduction was about 2 points. The main issue with this one was we had a very, very high heterogeneity. So heterogeneity, which was given by I-square, was 97%, which is way above the acceptable score of 75. So what I did is I tried to identify the 2 outliers and we moved them, and then we performed the same analysis which lowered, of course, the standard mean differences because obviously the outliers are the ones that have the highest impact. But I could reduce the heterogeneity to 72%, which is still quite high, but it is more acceptable. Afterwards, I looked at the risk ratio. So instead of using the complete reduction, now we're looking at the so-called cure. So you cannot technically cure someone of depression, but you can induce a remission. Remission means that the total severity score of the Hamilton Depression Scale is cut by 50%, and the final score went down below 7. So here we have an all or nothing scenario. We look at how many people entered remission in the placebo, how many entered the remission in the control groups, and then we look at this. As you can see, I had to remove one of the studies because the authors did not provide me with the absolute score. They only gave me the differences, and I needed the absolute score to see if there was cure. So obviously this time heterogeneity is not an issue because it's an all or nothing thing. It was cured, it was not cured. This time we have a risk ratio pooled of about 2.83, which is about 3. So what that means, again, in layman's terms, is that on average, if you undergo psilocybin psychedelic therapy, you are 3 times more likely to enter a complete remission of depression than a person who has not received that. The final thing I tried to do was to assess the publication bias and the finding of the true effect. So is there a bias in publication? Is there an actual true effect size to psilocybin? It is not completely random. So the P-curve analysis that I performed is like a novel tool, and it's quite hard to explain rapidly. I'll just try to give you an overview. Generally, the way it works is that, so if there's absolutely no true effect size to a study, every p-value would have the same likelihood, and the P-curve analysis would show a horizontal line. If every study was tampered with, every scientist would artificially push their study below 0.05 and reject everything that would be above. Then you would have a vertical line at p.005. If there was a true effect size and every study was absolutely perfectly done, then there would be every p-value would be 0 because they would just state objective facts. None of these actually ever happens in real life, but based on these things, you can derive a standardized graph, which you then can compare your P-curve analysis to that and then either reject or accept it. And with this one, we could reject the statement that there was publication bias, which this P-curve again has a p-value which is 0.02, 0.05. The conclusion, so the main conclusion obviously is that psilocybin works. So every single study that I found, except that one, showed an effect, and overall, both in absolute terms but also in remission terms, there was a significant effect. The main issue, like I said, was heterogeneity. So obviously, there's no clear guidelines how to perform psychedelic research. So my main recommendation for the future would be to standardize outcomes, to standardize the used scales to the same time frame, same patient groups, etc. Also, same dosage of psilocybin. Then afterwards, obviously, the future, now we know that psilocybin is more efficient than the placebo. Of course, we have to know, is it more efficient than the treatment currently? Because if it's the same as SSRIs, so there's not that much use to it. So for the next step, I would recommend also comparing it to current antidepressant treatment and also massively expand the pool of participants. So right now, we're only looking at major depression. In reality, most psychiatric patients have many comorbidities. They have anxiety, they have psychosis, they have other things, and we need to include these also. Finally, the last conclusion is that we have to consider the societal impact of this. So obviously, there was a hype in the 70s. Now we don't know would patients be receptive to this? Would doctors be receptive to perform this? Would insurance pay for this? These are all things we have to consider if we are dealing with a technically recreational drug. Thank you.
Thank you. Very good study, tough study, I would say. There is hope if I ever will become depressed. There is hope to be allowed to use substances. The ones I missed in the 70s because I was too young. There is a question from Professor Tacitano.
Congratulations, because this is a very nice analysis. So congratulations. I have 2 concerns. The first, when you look for studies on comorbidities, it would be the future, because actually we have a few studies only with old antidepressants, and this this is a big bias of mental
Yes.
disorder. And what do you think about the medium, long-term maintenance? Because we are going to try scattering, but this shot of, I mean, what do you think about times of treatment and relapses?
So the longest follow-up I had in my studies was about 3 years. So obviously in the scale of chronic depression, which is often a long-term disease that is not so long, everyone maintained their results after those 3 years. So it was a long-term change. And there was one study that attempted to reintroduce psilocybin again after 2 years, and it found no change. So it found no new improvement of the previous symptoms. But obviously, the time scale is very low. So currently, the maximum we can provide is 3 years. Beyond that, we don't know.
Thank you. The next candidate is Isabella Bianchetti. It's a great pleasure to call her at the podium. And she did a thesis work under the supervision of Professor Mistiko. Please, Stephen.
Thank you very much, Chairman, and it's a real pleasure to introduce Isabella. Katie attended with enthusiasm our clinic since I started my professorship in Sapienza, so she's my first candidate. I'm very proud of that. She worked in my outpatient service in the laser unit, and she will present a very interesting study on treatment of some complex issues that are very difficult to treat in dermatology, such as scars, especially keloid scars. So we are very happy to hear.
Thank you, Professor, for the introduction, and good afternoon, members of the Commission and Professor Damati. I'm very honored to present to you my dissertation thesis, which deals with the management of keloid scars, in which we introduced an innovative treatment approach that incorporates both ablative CO2 laser and pulsed laser therapies as an experimental clinical investigation. So the keloid scar is a pathological scar that is characterized by overgrowth of fibrous tissue, and the pathognomonic sign of this type of scar is that the growth expands beyond the original margins of the wound, which differentiates it from a simple hypertrophic scar. For what regards the pathogenesis of the keloid scar, the consensus is poor, and multiple theories have been developed over the years. And in my preliminary research, I created a simplified model that underlines 4 main influences, which are an imbalance in collagen turnover with excess synthesis and lack of degradation, an altered growth factor milieu with excess TGF-beta and PGF, environmental factors such as tension and mechanical stress. But what I would like to point your attention to is the genetic predisposition, as multiple studies underline the importance of this component because of a high familiar clustering, with 50% of patients presenting with keloids having at least one family member affected by the same disease, and especially high rates of incidence rates in populations with an ethnical background, particularly in populations with an African descent, with above 50% incidence. And the keloid scar is a complex scar because it has a physical symptomatology correlated to tension, hyperalgesia, hyperesthesia, and pruritus, as well as a strong psychological impact because of the nature of an exposed deformity. And in fact, the highest prevalence is on the auricle and the lobe. However, this high incidence of pathology and highly complex pathology keeps being understudied, and the treatment approaches underperforming. The conventional treatment methods that are used as a standard of care at the moment include these 4. The cornerstones are considered the intralesional corticosteroid injection and the surgical excision. Both of these are highly limited because of the strong recurrence rates, which some studies report being up to 100%. On the other hand, cryotherapy and radiation therapy were developed, but one important point to make here is that both of these are contraindicated, at least relatively, in patients with dark skin pigmentation, so with the skin Fitzpatrick type from 4 and above, which you can see it doesn't really compare to the fact that these are actually the populations that have the highest incidence of this pathology, so they cannot be considered the standard of care. In light of these limitations, we developed an innovative approach that we call the combined laser therapy, in which we used consecutively the ablative CO2 laser and the pulse-dye laser. Laser is actually an acronym for light amplification by stimulated emission of radiation, and it works by emitting light at a specific wavelength that corresponds to a target molecule that is present, in this case, in our skin, which is called a chromophore. For the ablative CO2 laser, the chromophore is water, so the action of this laser on the skin is complete tissue vaporization that leads to a reduction in the volume. On the other hand, the pulse-dye laser has a wavelength which on the light spectrum corresponds to red. So in our skin, this corresponds to hemoglobin. The effect of this laser is photothermocoagulation, leading to a reduction of erythema. So as you can see, with the combined laser therapy, we can address the two most important components of this scar, which is volume and the pigmentation. The therapeutic algorithm that we followed begins with the preliminary studies with the multispectral imaging, which allowed us to differentiate the predominantly vascular keloid from the predominantly fibrous keloid. The ideal candidate is the predominantly fibrous keloid, in which we first applied the ablative CO2 and consequently an intralesional pulse-dye laser, while in the predominantly vascular, we had to pre-treat with pulse-dye laser and then re-evaluate and perform the therapeutic algorithm again. In order to assess the scars, we utilized the Vancouver scar scale, which is actually the standard scale that is used for the evaluation of scars in dermatology, that evaluates the scar based on vascularity, pigmentation, pliability, and height. But we also wanted to add this other scale, which is the POSAS, that is comprises two parts. The OSAS, or the Observer Scar Assessment Scale, which is compiled by the observers, so the doctors, and the patient scar assessment scale, which is carried out by the patient himself. And for us, this was very important as we stressed the importance of the impact on the patient. So we wanted to include their point of view in the evaluation and the statistical analysis. So these are the raw data that we got out of our patients, but I think they will be better explained in the statistical analysis that I performed. On the right-hand side, you can see the estimation plots that we developed, in which on the left you see the values of both scales before treatment and after treatment. And on the right-hand side, you can see the mean difference with the confidence interval, which in both cases doesn't cross the zero line, indicating the statistical significance. So eventually what came out is that in the Vancouver scar scale, the reduction average was of 5.4 out of a scale that is 0 to 13. So we have a 63.1 reduction in scar severity, while in the POSAS, we have a 62.0 reduction in scar severity, indicating consistency between these scales. Now I would like to present a short clinical case. This is a patient that we had that had a keloid on the auricle, which was consequent to piercing. And as you can see in the multispectral imaging, the keloid used to be predominantly vascular, as you can see by the blue hue of the picture. So we had to perform a pre-treatment with a pulse-dye laser, and you can see how the volume is still there in the above picture, but with multispectral imaging, the vascular component is mostly resolved. And finally, we performed a vaporization in which we ablate completely, and this is the final result that we got from our patient in one sitting. So as a conclusion, I would like to underline the fact that we found a reduction in the severity of the physical characteristics and the clinical presentation, with a high improvement in the patient satisfaction and the quality of life, as reflected by the P portion of the POSAS scar assessment. The results were statistically significant, as I explained, but I would like to stress that this was a small unicentric study. So I would like to see in the future the expansion of this methodology that we introduced in a larger multi-center and especially randomized trials. And one thing that I would really like to see in the future is a standardized methodology in order to compare different laser types in order to provide the best standard of care for our patients. And this is it. Thank you for the attention.
Thank you. This is very nice work, very well presented, and I have to thank Isabella for what she did for the course. She did a wonderful job. And
Thank you.
This is something more. Anyway, are there any questions? Can I ask a question? Is this methodology new set up in this lab, or is it, relatively new? Because it's very interesting. And second question, only for keloid or other lesions?
So the combination between ablative CO2 and pulsed laser is created specifically for this type of studies. But for the principle of it, since it addresses the vascular component and the volume, can be used in other pathologies. First and foremost for acne scars, as also in that case, we have a texture problem and a pigmentation problem. So I would like to see that in the future.
So you are going to expand into the use of these
Yes.
methods. Thank you. Very, very interesting. The next candidate is Nikolai Igor Dudek. He did his work under the supervision of Professor Tarsitani. Please, Lorenzo, if you'd like to introduce his work.
Thank you, Professor Donati. Good afternoon. Nikolai is attended our psychiatric intensive care unit and worked on a dataset with a research question to compare infections treated involuntarily to infections treated voluntarily, and making a match in order to see some clinical characteristics different. And I think this is a very important area of mental health and psychiatry, and so go on.
Thank you very much for the introduction. Thank you, Professor Damati, for hosting this session. And thank you everyone for coming. This is the work that I did in collaboration with Professor Tarsitani and also with Dr. Matteo Panfili, who isn't here today, but he helped me a lot. The title is Acute Phase Mental Disorders and the Use of Involuntary Treatment, and it was a retrospective study in the psychiatric ICU. So first of all, what is an acute phase mental disorder? It's a mental disorder in which there are rapid onset symptoms that need to be treated immediately because the patient poses danger to themselves or to others. Mainly this is comprised of mood disorders such as bipolar and severe major depressive disorder, and also from psychotic disorders such as schizophrenia, schizophreniform disorder, schizoaffective, also substance-induced psychotic disorder and brief psychotic disorder. And then for the I'm going to explain also the involuntary treatment. So basically, it follows an extension of the Basaglia law, which is kind of famous in Italy. Basically, it states that when the patient is a danger to themselves or to others, the family member or the GP or another mental health professional can request the TSO, which means Trattamento Sanitario Obbligatorio, which is an involuntary hospitalization procedure. Whenever this happens, the patient needs to be evaluated by 2 physicians, and they need to come to an agreement, after which they send the report to the mayor, who can further approve the TSO to occur. And then within 48 hours of this, we need to send it to the judge, and he also has to approve. And the maximum amount of days that the patient can stay in the ICU is 7 days. but it can also be extended through the same procedure. So first of all, here we have a global map of the general prevalence of mental disorders, all grouped together in different countries. The mean is 13.6%. We can see in some of the countries that are in the developing world, we have to remember that there is underrepresentation and also underdiagnosis of mental disorders due to different cultural aspects and laws. Here we have another graph which shows that the rate of involuntary treatment is on the rise. This is a study done in China in 2019, and it follows 14 months. And in those 14 months alone, you can see an increase, which alone it shows that it's a rapid increase in the past few years. So we performed a retrospective study, which has some advantages and disadvantages. The advantages are that it's ethically feasible because we take the data already from the past. It's also practical, it's cost effective, it's time efficient, and it allows us to basically narrow down a lot of data into smaller packages and then form maybe future hypotheses for prospective studies. It also has limitations, however. For example, in our case, due to its observational nature, we cannot establish a causality, so these are merely correlations and hypotheses. And also in our study, we had a small sample size with 50 patients and 50 matched patients, so controls basically. But the reason that we match these patients is because it improves the generalizability and comparability of the study, because we minimize confounding variables and we improve validity. And so here you can see we started with a large database from 2006. We had 6,200 patients, from which were all patients that were admitted into the ICU, both voluntarily and involuntarily. From this, we decided to focus on patients that were admitted since 2017. Then we randomly selected 50 patients that were admitted involuntarily, and then we performed the matching based on their biological sex, their age plus minus 3 years, and their diagnosis. And then we performed statistical analysis using the SPSS software. So we have the first result and conclusion. We looked at the age of onset, if there was any difference between the patients that were involuntarily hospitalized and matches. And we basically found that on average there was a 4-year difference in the age of onset with a p-value of 0.027. And we can interpret this basically as we know that the earlier a psychiatric disorder manifests, the more severe it will become and the worse prognosis it has, leading to involuntary hospitalization. You can also see the difference in the bar graph. Then we looked at the duration of stay, and we found again a 4-day difference. So it was longer by 4 days. It was 16.6 days on average for involuntarily hospitalized patients. The p-value of 0.018. We looked also at the age of admission to just check if our matching was correct, basically, and the value is basically the same. The duration of stay we can basically interpret as the patients who are involuntarily admitted, they tend to have more severe symptoms, and for that reason they need longer hospitalization to receive more treatment, basically. Then we looked at alcohol, marijuana, and other substances, and we found that of the 13 patients in our 100 patients who tested positive for alcohol, 11 of those, so 84.6%, were in the involuntary hospitalized group. The p-value was 0.07. We found a similar result for the marijuana and also other substances, where it was 90% for both of them. Here we can see on a bar graph, we compared in blue the alcohol between involuntary and voluntary, in green the marijuana, and in orange the other substances. We can basically interpret this as, since alcohol is a disinhibiting substance and also very addictive, it alone is a dependence disorder and can lead to further social and psychological distress, which can worsen basically other mental disorders. For marijuana, it's been shown in recent years that actually marijuana can trigger psychotic disorders such as schizophrenia, and also for other substances, it's the same. And so what should we do for the future with a retrospective study? We can do longitudinal studies to track the long-term outcomes of these patients. We can do also comparative effectiveness research, which we compare different treatment modalities between the groups. We can do interventions to reduce involuntary admissions, so do, for example, test programs and basically develop these programs that we can screen for these risk factors that we have found in the study. We can also look at the patient and family perspectives, because this involuntary admission to a hospital is a very stressful and impactful procedure on both the patient and the family and everyone surrounding. And it itself can actually cause more psychological distress. We can also look at the policy and legal impact. So basically, to see how different legal frameworks influence voluntary treatment rates and outcomes, for example, between different countries. And then we can do also predictive modeling, which we create models to identify high-risk patients. And we can also investigate the impact of early onset and study the long-term effects of early onset and disease severity and prognosis. And that's it. Thank you.
Thank you very much. This is very interesting. And the other questions? Professor Fabini?
Thank you very much. Very interesting and important work. I saw that there is a difference in the time of stay in the hospital. There were also problems in discharging patients. In other words, these patients, sometimes you cannot find a place where to stabilize them or to send them after the stabilization.
Yes, absolutely. Yeah. So basically, the patients can be sent either they can be discharged to a home, they can be discharged to they can be transferred to another psychiatric ICU in a different hospital, or they can be discharged to like a community psychiatrical center where they can live. However, not all patients fit one of those three categories. For example, patients that don't have anywhere to live, but they don't have a disease severe enough to be put in like a permanent like an institute. So yeah, there is difficulty for this. Also, that's why we can see also increased duration of stay in these patients.
Does it have the same impact on voluntarily hospitalized patients, or is it the problem finding a place after is more pronounced in patients involuntarily admitted, or is more or less the same also for other patients?
No, I would say it's more the same, and even it's more regarding the involuntary patients more than
It's a big problem. Okay, thank you very much.
Thank you.
The next candidate is Vespuina Cineri. She did work again with Professor Tarzitani. And I'm sure it was an excellent work as well. Please, Lorenzo.
Yes, Medicina will change area, and Medicina worked on a secondary analysis of data set of the large international trial on the WHO World Health Organization psychological intervention provided to asylum seekers or refugees recently arrived in Europe. And she worked on, with the mediation analysis, she worked on the impact of traumatic events and post-traumatic symptoms on the outcome of this group intervention. Go ahead, please.
Good afternoon, everyone. First of all, I would like to thank the Commission and my supervisor and my co-supervisor that he's not here today, but he really helped me with this presentation. I would like to present you my thesis with the title Effect of Trauma on Asylum Seekers and Refugees Receiving a WHO Psychological Intervention and Mediation Model. Nowadays, migration has become a major problem in our society. Refugees and asylum seekers are facing numerous challenges before, during, and after migration. and they're exposed to a great number of potential traumatic events. They are at a higher risk to develop some mental health conditions and psychological distress in comparison with the native population. One of them is the post-traumatic stress disorder. That is a mental disorder that can be developed after being exposed to a threatening event and can be presented with psychological and physical symptomatology. Post-traumatic stress disorder may have a great impact on the effect of some unspecific psychosocial interventions. Nowadays, many scalable psychological interventions have been developed to help clinical and non-clinical populations that they are in need for psychological support. One of them is the self-help class intervention that has been developed from the World Health Organization. It is a form of cognitive behavioral therapy that is based on commitment and acceptance. And more specifically, it is a group setting therapy that includes 5 structure sessions. Approximately they last 90 minutes each. And it is delivered by non-specialists that they can use book, audiovisual material, relaxation techniques, and some guided exercises to help the participants to reduce the mental distress and the functional impairment and to practice mindfulness. Here we can see the aims of the study. The first one was to evaluate if the total number of potentially traumatic events predicts the level of improvement following a self-help class participation in terms of psychological distress, well-being, and quality of life in a group of refugees and asylum seekers. And the second was to study if the relationship between potentially traumatic events and response to the self-help class is mediated by post-traumatic stress disorder symptoms. We retrieved the data from 2 randomized prevention trials that involve asylum seekers and refugees in Western Europe and in Turkey. And only the participants that they were able to conclude 3 sessions where 3 sessions of the self-help class intervention were included in the study. We measured the exposure to potential traumatic events at baseline using the Harvard Traumatic Questionnaire. Here we can see the inclusion criteria that was age more than 18 years, speaking Arabic, English, and Dari, being under temporary protection, and experiencing psychological distress. Participants with mental disorders, acute medical conditions, suicide risk, and impaired decisions were excluded from the study. The assessments were made at 3 time points. We measure some mental health problems were measured at baseline, like psychological distress using a general health questionnaire, post-traumatic stress disorder symptoms using the PCL5, depression symptoms using the patient health questionnaire, functional impairment using the WHO disability assessment schedule, and then psychological welfare was measured, like well-being and quality of life. For the statistical analysis, we used unadjusted regression models, as well as adjusted models with sociodemographic variables, and some models that included indirect effects to prove the mediating role of post-traumatic symptomatology. 345 participants were able to conclude the 3 sessions. 55% of them were women. The mean age was 33 years old, and years of schooling approximately 9 years. The length of stay in the host country, 45 months. They were mostly unemployed, and they present mild symptoms of depression and post-traumatic distress symptoms, as well as a low quality of life and level of well-being. Here on the map, we can see the main countries of the participants' origin. We can see that the greatest percentage was coming from Syria, followed by Nigeria and Iraq, all moving towards Europe. And as I said before, we first tested if the number of potentially traumatic events predicts the response to the self-help class intervention in terms of psychological welfare and mental health symptoms. Here we can see the results from the adjusted non-mediated model that saw a significant direct correlation between total numbers of potential traumatic events and mental health symptom scores, and a reverse one with psychological welfare measure scores. And we additionally tested the mediation role of post-traumatic stress symptoms in the relationship between potentially traumatic events and the response to the self-help class in terms of well-being and quality of life, and using an adjusted model. And we found a joint significance for all the direct effects and as well for the indirect mediator effects. And we use a similar adjusted model to prove the mediation role of post-traumatic stress symptoms, but this time in terms of mental health symptoms. And this time we found a joint significance for all the direct effects, but not for the indirect mediator effects. So we concluded that all the participants exposed to multiple potential traumatic events, they may benefit less from the self-help class intervention in terms of both mental health problems and psychological welfare, and that post-traumatic stress disorder symptoms play an important role in the participants' well-being and quality of life, and they may reduce as well the benefits of participations from such scalable interventions. So healthcare professionals and researchers should be aware of the role of trauma and post-traumatic stress disorder symptoms, and they should focus more on the treatment of asylum seekers and refugees using such scalable interventions like the self-help class intervention to address post-traumatic symptoms in traumatized subjects. Thank you for your attention.
Again, this is a very interesting work pointing to a well-known condition and for which there are several proposals, but not really solutions at this time. So basically, this is an intervention which is somehow effective on a subpopulation of patients, basically, or it's also kind of. Do you think it could be used also as a screening method, like patients who go on and the others need more, practical treatments or something like this?
You mean a more effective treatment of the self-help class?
Yeah, because you can use it as an effective treatment, so as a kind of a screening method.
Yes, it has been proved to be effective also in past studies, and it is not only specific for post-traumatic distress, but for psychological distress and other mental health symptoms. So I think that is a very useful tool for treating mental health conditions in immigrants and refugees, and I will say that it could be used as
yes, I think it's, but it's not. I mean, of course, there are conditions affecting its efficacy, of course. Yes. But it's a very good tool. Yeah. Other comments? Okay.
Thank you.
Okay, the next candidate is Matilana Cavini Veranga. She did her thesis work with Professor Danilo Toni. Will you introduce?
Yes. So this work by Cavini is on a very long debated argument in the field of cerebrovascular disease treatments. Since the advent of the mechanical thrombectomy, the intravascular treatments, which are done only in second-level hospital, which is the highest complexity of organization in this country, the question arises whether it was more effective bringing the patient directly to the second-level hospital, the so-called mothership model, or it was better or equal bringing the patient before first in a peripheral hospital, first-level hospital, to do their thrombolysis and then move the patient to the second level, the so-called drip-and-ship. A vast literature has been produced on this issue, even a couple of randomized control trials with inconclusive results and contradictory results. And curiously enough, no data from Italy. And as far as I know, this is the first contribution from Italy on this issue, on which Cavini has worked hardly and very participating. So I'm asking her to show us the data.
Thank you, Professor Tony. Good afternoon to everybody. So as the professor was saying, our study was a territorial analysis done on the Policlinico Umberto I stroke network. So when it comes to acute ischemic stroke, the recommended treatment is to perform mechanical thrombectomy with or without intravenous thrombolysis. So as the professor was saying, there are centers that are capable of performing mechanical thrombectomy and centers that are not. So when it comes to the patient transfer between different centers, there are two main modalities, that is the mothership model and the drip and ship model. In the mothership model, the patient is transported directly to a comprehensive stroke center that is capable of performing mechanical thrombectomy, whereas in the drip and ship model, the patient is first transported to a nearby hospital where they may receive intravenous thrombolysis if they are candidate to do so, and after which they are transported to a comprehensive center to undergo mechanical thrombectomy. So in the past several years, there have been meta-analyses that were performed that demonstrated that the mothership model in fact had significantly improved functional outcomes when compared to the drip and ship model. But on the other hand, there were some randomized controlled trials, such as the RACE-CAT trials, that did not show any superiority of one model over the other. When it comes to our Lazio region stroke network, it is arranged in a decentralized system of hubs and spokes, where hubs are highly specialized centers that have the UTN level 2 facilities and can perform mechanical thrombectomy, whereas spokes are hospitals that can only carry out intravenous thrombolysis. So when we look at the Policlinico Umberto I stroke network, as demonstrated in this diagram, you can see that our polyclinical hospital is the hub with level 2 UTN facilities, and it has functional connections with different levels of spokes. So San Giovanni Tivoli Hospital and San Giovanni Rome hospitals should have UTN level 1 facilities, whereas hospitals in Subiaco, Palestrina, and Pertini only have Pronto Soccorso DEA facilities. And when it comes to the patient transfer, we have the mothership model, where patients in the direct catchment area of Policlinico Umberto I are brought directly to the hub, whereas patients further away from this catchment area are first brought to the spoke, after which they are transferred to the hub, the so-called drip and ship model. So the objective of our study was to evaluate the effectiveness of our stroke network by comparing the mothership and the drip and ship models. And we did this by assessing as primary outcomes the 90-day functional outcomes using the MRS score. So the MRS score, also known as the Modified Rankin Scale score, is a score that ranges from 0 to 6, with 0 indicating the patient has no symptoms, whereas 6 indicates death. So in our study, as the primary outcome, we assessed MRS 0 to 1, which is an excellent outcome, and 0 to 2, which indicates functional independence. Other than this, we also looked at the 90-day mortality and early neurological improvement at 24 hours and 7 days. As secondary outcome, we evaluated the influence of the workflow on different outcomes, and we assessed the workflow by looking at different time intervals, for example, the door to recanalization time. When it came to the patient selection, patients were those who had large vessel occlusion, ischemic strokes that were treated in Policlinico Umberto I and underwent mechanical thrombectomy during the period of January 2018 to July 2023. So we collected the patient's demographic factors, their cardiovascular risk factors. The stroke severity was assessed using the NIHSS score at baseline, at 24 hours and 7 days. And the MRS value was recorded pre-stroke and again at 90 days. And finally, the modality of the patient transport was noted. And then we calculated finally the intervals such as the door to needle time, door to angio-suit time, door to groin puncture, and door to recanalization. Looking at our results between the mothership and the drip and ship model, we in fact did not find any significant differences in the characteristics of the patients. So concerning the age, the sex, the cardiovascular risk factors, none of them were statistically significant between the two groups. And even concerning the severity of the stroke, looking at the baseline NIHSS, we can see that the difference was clinically relevant, though not statistically significant. And when we consider our time intervals, the door to needle and the onset to recanalization times were significantly longer in the drip and ship model compared to the mothership model. Whereas on the other hand, the door to angio, door to groin, and door to recanalization times were significantly longer in the mothership model compared to the drip and ship model. And when we assessed our primary outcomes, we did not, in fact, find any significant difference between the mothership and the drip and ship regarding the 90-day functional outcome, nor regarding the mortality at 90 days. And again, looking at the early neurological improvement at 24 hours and 7 days, again, we found no significant difference between the two groups. Regarding the workflow and its effect on the functional outcome, so we did a multivariate regression analysis concerning the whole population, that is both the mothership and the drip and ship. But again, here we did not find a significant relevance but as you can see, the door to recanalization had a trend. It had an impact on the 90-day functional outcome, where longer door to recanalization meant that the patient had a less chance of achieving good outcome at 90 days. But we found a significant relevance when we considered the early neurological improvement. So a longer door to recanalization time meant that the patient had less chance of achieving early neurological improvement at 24 hours. And finally, again, when we consider the duration of our mechanical thrombectomy procedure, we found significant results with longer duration of procedure, leading to the patient of having a less chance of achieving 7-day early neurological improvement. So finally, our conclusion was that since there was no significant difference in the clinical outcomes between the mothership and drip and ship models, our current decentralized stroke network of polyclinical is in fact effective because no one model showed superiority over the other. But we do need to implement protocols that can improve the in-hospital workflow so we can achieve faster recanalization times, because as demonstrated by our study, they do in fact have an impact on the patient's early neurological improvement. Thank you.
Congratulations, this is a very nice work. There is hope for people with the stroke, which is very, very good. Is there a kind of correlation between the mental status of the patient and the ability to make the diagnosis? Are there confounding factors? Because I see that there is a longer time from indoor to, I would say, balloon, talking about TCA balloon.
Yes.
Which are the factors affecting from the patient point of view, not from the hospital?
Because
are there any factors affecting
right? So
the time?
when we consider like door to reperfusion, as Professor was saying, the door we consider is the hub. So the patient's delay factors would affect even before the pre-hospital part of it. And we consider that, we did not consider it here, but of course proven in literature is that these delays can occur on the patient's part, which are like primary delays, because they do not realize they have a stroke, or they do not realize the severity of their symptoms. And these, in fact, do have an impact on the final outcome of the patient. So these we would have to look at from onset to recanalization to assess these parts. But we were, yeah.
In the case of myocardial infarction, the feeling pain is,
Exactly, which is well more known. So we need to actually implement also more campaigns so that patient awareness is increased.
Exactly, the awareness is important.
Yes.
Thank you.
Thank you so much.
The next candidate is Sena Atun. He did the work under the supervision of Matteo Bologna, who's going to present her work.
Good afternoon. I'm very much pleased to introduce Sena. During her internship, she has actively participated in our research work in our research group, and now she is going to present our research study on essential priorities. Basically, this is a retrospective analysis of clinical and kinematic data showing essential kind of worsening after SARS-CoV-2 infection.
Thank you, Dr. Bologna, for the nice introduction. Honorable jury, dear Professor Damati, dear audience, today I'm going to be talking about the retrospective clinical and kinematic analysis that we've done in order to investigate the impact of SARS-CoV-2 infection on essential tremor. Before I start, I'd like to have a few words on essential tremor and SARS-CoV-2. First of all, what is essential tremor? And before that, what is tremor? Tremor is an involuntary rhythmic oscillatory movement of a body part. It basically looks like this on a patient. And essential tremor in 2018 has been defined by the International Parkinson's and Movement Disorder Society as an isolated tremor syndrome of bilateral upper limb action tremor of at least 3-year duration, with and without tremor in other locations, in the absence of other neurological signs. Now, this is a very thorough definition, and this makes essential tremor a clinical diagnosis. What else can we say about this definition? We can say that it highlights some points about essential tremor, that it's heterogeneous and that it's a chronic disease. Due to the fact that it's a heterogeneous disease, it's also very prevalent. It can be found in up to 4% in some population groups. And the pathogenesis of the disease being very complex is still not quite well understood. We do know that it involves cerebellar pathology, both through in vivo works, in vivo functional works, and also the post-mortem pathological works, histopathological works that are done. Due to the fact that we do not really understand the pathophysiology, the cure we do not actually have. We don't have a curative treatment. We mostly do symptom treatment. What about coronavirus 2? As we all know, it is a positive-stranded RNA virus from the Coronaviridae family, and it is the etiological agent that was responsible for the COVID-19 global pandemic. The virus itself uses the ACE2 receptors that we can see over here in order to bind the cells and enter the cells. And upon entering, it can cause both viral damage as well as immune-mediated damage. This causes patients to have several different clinical manifestations, which changes from asymptomatic to influenza-like symptoms in most of the patients, and in some patients, multiple organ involvement, and it can lead to death, as we will all very clearly know. What about the neurological implications, though? With SARS-CoV-2 infection, we found that we can have new neurological implications, as well as the worsening of the previous pathologies of nervous system. And how about in the case of essential tremor? So far in the literature, there are only 2 works that are studying the effect of essential tremor on the effect of SARS-CoV-2 infection on essential tremor, and these are both case studies, case reports. And here we can see that the patient's tremor, as we said, it's a chronic disease. So the patient's tremor was getting worse, but upon infection, it actually gets worse when we check the clinical tremor scores, the score increases, and then after the infection, the score decreases, which is a very interesting finding. The kinematic findings that we find also support this. But as I should once more reiterate, these are just case reports that are done on 2 patients. So the objective of this study is to evaluate the impact of SARS-CoV-2 infection on a broader sample of ET patients, checking both subjective tremor worsening, asking the patients how their experience was, then through the clinician's eyes, using the clinical changes assessed by standardized scale. The scale we use is Van Tolosa-Marin Tremor Rating Scale, which is a very well-spread used test, as well as objective tremor changes that are analyzed by kinematic tremor analysis. How did we do that, though? So we already had a pool of patients that were undergoing periodic evaluations for their essential tremor, both clinically as well as kinematically. We got their informed consent to participate in the study, and then we asked them if they had been infected with COVID. For the patients that were infected with COVID, we asked them to actually confirm their infection through a nasopharyngeal swab, and then we asked them a very basic questions. Have they realized a worsening in their tremor upon infection? Then we went retrospectively and we looked at their both clinical and kinematic data, and we tried to find an association as to how their tremor changed. So as for the clinical data, as I've said, we use the Van Tolosa-Marin Tremor Rating Score, which takes into part 3 parts, the part A, part B, part C, and then the summation of these 3 parts, the total score. Part A looks at the severity of tremor. So if the patient was tremoring like this, did the amplitude increase? The part B looks at task specificity. So the patient is supposed to do these spirals that you can see over here that are also called Archimedes spirals, and they're supposed to draw a line. As you can imagine, the worse the tremor, the more jiggly the lines are going to be. Then we did the kinematical data analysis. We used these accelerometric sensors that you can see over here and these pins. And these pins are basically put on top of the patient's body, which creates these stick-like figures that you can see over here. And it helps us see objectively the the amplitude as well as the frequency of the tremor. What did we find? First of all, for the phone survey, we contacted 48 patients and only 36 of them have agreed to be a part of the study. Out of these 36 patients, 25 of them have said that they have been infected with COVID and they had positive nasopharyngeal swabs. And when we asked these 25 patients how their tremor scores were changed, if they actually subjectively felt a worsening in their tremor, 11 of them, so nearly 50% of them, have said that they haven't realized a change in their tremor. This is very interesting. Then, when we checked for the date of infection that they had, we realized that out of these 25 patients, 13 of them had the infection between two assessments. So it gave us a T0 and a T1. And we checked the clinical data that we had. First of all, as I said, these patients, these 13 ones, they had their infection between T0 and T1. The mean time between the T0 and T1 was 38 months, and the infection was most of the times 5 months before the T1, which is a good sign for us. If you look at the pharmacological and tremor rating scores, as I said, here you can see the total score, score A, score B, and score C. We realized that score B and score C had a significant increase upon infection. This is interesting because it shows that the test specificity and the activities of daily living are actually significantly affected by the infection. If you look at score A though, so the amplitude of tremor, and wherever it went, we realized that there is no significant change, which was an interesting find out. Since the total score is the summation of A, B, and C, we can see that total score also significantly changed after infection. When we check the kinematic data, we also find some results that were similar to the ones that we find in subscore A. The amplitude and the frequency of the tremor had not changed upon infection, but the tremor had spread to different parts of the body, and also the activities of daily life were affected much more significantly. So, if we come to the discussion, this is the first study to specifically investigate the relationship between SARS-CoV-2 infection and the changes in tremor in ET patients. A substantial portion of patients reported a subjective tremor worsening after infection. When we look at the clinical and kinematic data, we found that the tremor actually worsened. However, it didn't worsen in amplitude or frequency, but it worsened in the sense that it spread to more body parts. Head was also very, very much affected. And it also started affecting the activities of daily life very significantly. Now, this shows us a possible clinical and pathophysiological implication, which is the role of cerebellum. So far, there are no studies that show that, as far as I know, that SARS-CoV-2 has an invasion in cerebellum or causes inflammation in cerebellum. However, due to the fact that ET pathophysiology is actually very much correlated with cerebellar dysfunction, our study actually suggests that there might be an involvement. As I said before, the postmortem studies on I'm sure you're going to love this part, Professor Damati. It actually shows that we have Purkinje cell, axonal loss, we have basket cells, we have tornadoes, all these changes. So we're assuming, we're suggesting that there might be a change also histopathologically upon infection, which actually makes the disease go further. So as for the conclusion, although there are some limitations, one of which we only had 13 patients to do the clinical and kinematic analysis, as well as we might have lost some asymptomatic patients because the first positivity that we got from patients was self-reported. This study contributes significantly to understanding the long-term neurological implications of infection. We suggest that there's a potential correlation between viral infection and worsening of tremor. However, we're also aware that further research is needed to gain a clearer understanding of the impact. We need longer-term follow-ups to possibly check the impact of long COVID on tremor and how that works, as well as we need to evaluate the pandemic's associated factors that might have actually affected tremor. The patients were isolated, they were anxious, and they had fewer follow-ups. So this might also have caused a certain understanding of worsened tremor. Having said this is all my presentation. Thank you for your attention and time.
Thank you, Senna. It was very nice and also very well presented, I have to say. Are there any questions about this manifestation of long COVID? I mean, it's a further aspect of long COVID. I agree with you that a longer follow-up will be crucial also on control patients, because maybe COVID infection for several reasons causes a kind of a sudden increase in the symptoms, and then it levels up with other people if we don't really know. This is only a very short time. But the correlation with the COVID infection, with the SARS-CoV-2 infection is too. It's
Definitely. Actually, I did not present that part, but if you go back here, out of the 11 patients who did not report an infection, we've also retrospectively checked their data, and they did not show these changes. So we actually even have like a control here that shows that these changes do not happen in patients that do not go through infection. What I would add to your comment over here is that what's important is, I believe if you look at the case studies that I said before, they actually got better. Like the tremor scores, they increased at first, but then they got better and they pretty much lined up with the previous scores. So probably this might be either a long-term thing or it might be a short-term effect that we have with tremor. But again, we need a bigger sample size and long-term follow-up.
Thank you.
Thank you.
Last candidate is Michele Pepino. He did a very nice study on the ultrasound-induced cryoablation in breast cancer with Professor Pediconi, who's going to introduce him. I think it's a very nice study because I'm involved, of course. I'm sponsoring the project.
So thank you, Professor Damati, ladies and gentlemen. It is my great pleasure to present Michele. That is a very precise and enthusiastic student. He performed a pilot study on the rule on efficacy of cryoablation in early breast cancer patients. This is probably the first study on this clinical setting of patient breast cancer. And we evaluate the results and the outcome, evaluating the efficacy of cryoablation based on surgical treatment and also based on imaging features after contrast enhancement, and both on MRI and also ultrasound mammography. And of course, we perform the results together with the ecological groups and shared by Professor Damati. Please, Gary.
Thank you, Professor, for the introduction. I would like to thank all the commission and, of course, Professor Giulio Damati. Thank you for being here. So the title of the study is Efficacy and Safety of ultrasound-guided cryoablation in early-stage breast cancer. Outcome prediction with MRI and contrast-enhanced mammography. Breast cancer is the most common malignant neoplasm in women, and it accounts for nearly 29% of all the cases. The incidence is rising, and it accounts as of 2023 for 55,900 cases. However, thanks to the early screening programs, early treatment, and early diagnosis, the mortality rates have been decreasing since the late 1990s. Cryoablation is one of the only many procedures that have entered the realm of breast cancer, which uses low temperature to kill the tumor, maintaining intact membrane proteins and potentially enhance an immune response. The aim of the study is to evaluate the efficacy and safety of the cryoablation treatment on early-stage breast lesion, more specifically T1 and 0. We verified this outcome through surgical sample, and this was done by Professor Giulio Damati. We also assessed these findings through MRI, magnetic resonance imaging, and CM, contrast-enhanced mammography. The I study is a prospective single-center pilot study, which was done from March 2022 to January 2023. The inclusion criteria were that the women needed to be of 18 years or older. As I said before, they needed to have an early-stage breast lesion. They needed to be eligible for surgery, either quadrantectomy or mastectomy. The lesion needed to be less than 2 centimeters in size, more than 1 centimeter from the skin, and more than 2 centimeters from the nipple. These are the stages of the study. In stage 0, the patient was evaluated through consent, visit, and histological result from previous ultrasound-guided biopsies. In stage 1, within 10 days of stage 0, we performed imaging, either through MRI or CM. In stage 2, cryoablation procedure was done at least 24 hours later, and within 7 days, the imaging was revealed. In stage 4, surgery was performed and the surgical specimen were sent for examination. In the final step, at least 10 days after surgery, the patients were given a satisfaction question. The cryoablation procedure is a minimally invasive procedure, which in total takes about 25 minutes, and it is performed in an outpatient setting. A small incision of 3 millimeters is done on the breast of the patient, and a probe is inserted and through ultrasound guidance located at the tumor site. Then, thanks to high-pressure argon gas, the 17-gauge needle goes through 2 cycles of freezing and thawing, either passively or actively. Here we have the formation of an ice ball, which kills the tumor through coagulative necrosis. Once the procedure is finished, the probe is removed, hemostasis is achieved through manual compression, and a small bandage is applied over the small 3 millimeters incision. The most common complications if present are swelling, tenderness, and hematoma. These are the results. In 9 out of 10 cases, we had complete ablation. Only in 1 out of 10 cases, partial ablation was achieved. However, imaging correctly predicted all our outcomes, so with 100% negative predicted value. Why 9 out of 9? Because one of the patients refused contrast post-procedurally, so we reviewed the patient through ultrasound. All the patients reported high level of satisfaction and tolerability, with an average reported pain of 2 and a satisfaction level of 9 out of 10. All these patients were recommended this procedure both from an aesthetic and psychological point of view. Here we have a review of one of the cryoablation successes. In the first picture, we have an axial projection of the breast post-contrast in a T1 weighted imaging, where we can see tumor enhancement pre-procedurally. The second picture is a post-procedure, where we see the tumor ablation and only small peripheral rim enhancement, which indicates inflammation. These findings are confirmed in the last picture, where we have the surgical specimen. This is the 1 out of 10 cases that I was talking before, where the cryoablation was unsuccessful. The first picture is a midolateral oblique projection of the breast, pre-contrast. The second one is post-contrast, where we can see tumor enhancement once again. The third one is a craniocaudal projection of the breast, post-contrast. And the last picture is the post-procedure, post-contrast, where we see a 4 millimeter enhancement, which indicates that the tumor is still present. Once again, this is confirmed by the histopathological examination. In conclusion, we can say that our study correctly evaluated the efficacy and safety of this procedure in early-stage breast lesions. MRI and CM correctly predicted all the outcomes, and all the patients reported high level of satisfaction and tolerability. In the future, we plan to expand our cohort to validate our findings even more, and potentially investigate the systemic immune response in patients that undergo cryoablation, and compare this to patients that do not undergo the cryoablation procedure, and combining this treatment with immunotherapy, which could have a synergistic effect on the patient. Thank you.
Thank you, Michele. Very nice study, and you really presented very well. Of course, I like the study. I'm a part of the study, but what is amazing is the exact correlation between the MRI images and the gross pictures. Exactly the same. Yes. Which really, and histology, which really, gives more support to the idea that pathology is not only pathology, it's clinical pathology correlation, the way we call our exam. Listen, can you give us some insight very quick about the role of the immune system in this procedure, which is the added value?
Of course, yes. This is, of course, the future of the study, to check the immune response, as I said. There are other procedures that have entered in the realm of breast cancer. However, all the other procedure uses high temperature to kill the tumor. What happens is that through high temperature, with the nature of the tumor proteins, so which does not happen in the gravitational procedure because the membranes is still disrupted, but we have the release of tumor antigens that are embedded inside the cell. So the idea is that our body, through antigen presenting cell, would take this antigen present in T cells and potentially having an immune response. So not only the granulation can kill the tumor, but potentially increasing an immune response and being, as it is described, as an in situ vaccine.
It is time for us to leave you for a very short time. I think I don't think there will be problems, of course, but just wait for us. We will be back for the best part of the story.
Quanti siamo? No, alzate più qua, ragazzi, perché se non ci stiamo. No, la macchina è stata attenta.
Federica.
Guarda di là, forse non c'è anche della scuola. Senza direttore di come è qui? Siamo? Ci siete?
Here we are. Well, we are ready for one of the best moments of your life, I hope. And it will be a day of joy after 6 years of hard work, sometimes struggling sometimes. But I hope you will carry with you something of this course. I hope we were able to provide you with an example of how an excellent doctor like you will do should behave. We hope we've been examples of listening, caring, guiding students and patients. The quality of your work has been excellent. Everybody in the committee agreed you did an excellent job. You were very, very good presenting your data. You defended your data in a very positive way. And I'm sure your families can be proud of you. I'll be reading the acknowledgements on your thesis, and each one of you had a word for his family, for those who are still here, and for those who are not here anymore, but they live in your hearts and they are here, I'm sure, in this moment. And there is a very nice friendship within this classroom. I've been looking to the gratitude expressed to your companions and friends. So I think you are ready to go out in the world. Hopefully, some of you will stay in Italy, hopefully, and really you are ready to be excellent doctors. But to be excellent doctors, you have to listen to our representative of the Ordine dei Medici, Dr. Pasquale Franciosa, who will give you some instruction, and of course, he will welcome you to the world of official medicine.
Good afternoon. Thank you very much for the presentation, Chairman Martin. Today I represent the Medical Association, and my presence today is justified for the fact that the degree on the law of the 2020 is due qualify. So today, after once we have obtained the degree, but we have to evolve for the medical practice. All the work are good, very good, and after that.
Okay, so we can start. Melina Eleni Baltogianni. The community has evaluated positively your CV and your thesis. So by the power entrusted to me by law and the head of the rectress, I'm really proud to declare you doctor in medicine and surgery with a degree of 93. Congratulations. You see? The next is Wasfi Kashraf Rashid. And the committee has evaluated positively your CV, your thesis, and the way you presented your data, thereby by the power granted to you by law and entrusted by the beneficent rectress. I'm very happy to declare you doctor in medicine and surgery. Congratulations. Very good. Perfect. Sena, Arthur. The committee has evaluated very positively your CV and your thesis and excellent presentation. Everybody agreed on this. Thereby, by the power entrusted to me by law and by the rectress of this university, I declare you doctor in medicine and surgery with a degree of 107, and congratulations. Nikolai. The committee has evaluated very positively your CV, your study, your work, the way you presented your thesis, and thereby I'm very happy by the power entrusted by law, granted by our magnificent rectress, to declare you doctor in medicine and surgery with a score of 108. Please, Tom Labowski, please come. How could I forget you? After all we did together, after all what happened in these years, you were always an excellent student. Your thesis work has been extremely good. So I'm really happy by the power entrusted to me by law and granted by our rectress to declare you doctor in medicine and surgery with a score of 107 and many, many congratulations. Despina Cinieri. Despina, I made a mistake. I called you Despoina. You are Despina.
I said that.
Despina, the committee has evaluated very positively all your CV and your very nice work and the way you presented your data, thereby by the power entrusted to me by law and granted by the rectress of this university. I'm very proud to declare you doctor in medicine and surgery with a grade of 110. Isabella Iacchetti. I must repeat, you did an excellent job, not only as a student, but also as a student representative. You did work a lot for our degree course. You were so active, and I really appreciate these efforts, which are giving some results, and I'll tell you later on. So and of course, your thesis work was really excellent, the way you presented. So you are all set to become an excellent doctor. By the power entrusted to me by law and granted by the rectors of this university, I'm very happy to declare you doctor in medicine and surgery with a score of 110 with honor. Francesco Lo Iacono. Francesco, the committee evaluated very positively your CV, your wonderful thesis, the way you presented the data. So I'm very happy by the power entrusted to me by law and the rectors of this university to declare you doctor in medicine and surgery with a degree of 110 with honor. La procedura. Fabian Filippini. Fabian, we really enjoyed your thesis and the way you presented. Your CV is excellent. So I'm very happy that under the power entrusted to me by law, granted by our rectress, to declare you doctor in medicine and surgery with a degree of 110 with honors. Cavini, Cavini, your CV is excellent. You did a very good job. You presented very well. So we are really, really happy. And we really congratulate you. And this is the time, by the power entrusted to me by law, by the rectress of this university, I'm really happy to declare you doctor in medicine and surgery with a degree of 110 with honors. Michele Pipino. I don't have to comment on your CV because we've been, talking to each other for such a long time. We've been sharing many experiences. You are an excellent student. Your CV speaks well about this. You did an excellent job. I'm sure you will be a very good doctor. Thereby, the power entrusted to me by law, granted by our rector, I'm really delighted to declare you doctor in medicine and surgery with a degree of 110 with honors. Chiara Santellani. The committee has evaluated very, very positively, I have to say, your CV and your thesis work. Thereby, I'm very, very happy under the power entrusted to me by law and by the rectors of this university to declare you doctor in medicine and surgery with a degree of 110 with honors, and you will be the one who will read the Hippocratic Oath. Okay. Okay, the hat. Okay, come here and look to those here surrounding her.
You can keep the head.
And look to the ones who did all this for you, the ones who were with you all this time,
You can go.
supporting you.
The podium.
You go to the podium, supporting you, helping you, trusting you. So this is a wonderful day for you, excellent doctors, and for your families and friends. Okay, we are proud of you and we want to be proud of you in the future. Okay, please go ahead.
I swear by Apollo, the healer, Asclepius, Eugenia, and Panacea, and I take to witness of the gods, of the goddesses, if according to my duty and my judgment, the following oath and agreement. To consider dear to me as my parents, him who taught me this art. To live in common with him, and if necessary, to share my duty with him. To look upon his children as my own brothers, to teach them his art. I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. I will not give a lethal drug to anyone if I'm asked, nor will I advise such a plan. But I will preserve the purity of my life and my arts. I will not cut for stone, even for patients in whom the disease is manifest. I will leave this operation to be performed by practitioners, specialists in this art. In every house where I come, I will enter only for the good of my patients, keeping myself apart from all intentional evil within, and all seduction, and especially from the pleasures of love with women and with men, by the free of forced slaves. All that may come to my knowledge in the exercise of my profession or in daily commerce with men, which ought not to be spread abroad, I will keep secret and will never reveal. If I keep this oath faithfully, may I enjoy my life and practice my art, respected by all men and in all times. But if I swerve from it or violate it, may the revert be my loss.
Bravo.
As I told you before, I'm sure you will do it because you are good doctors. Don't make noise where patients are suffering. Okay, floor just above. So you can leave and celebrate. I think you could start with a week of celebration at least. Okay, starting from now, but not close to the Prima Clinica Medica. Okay, I hope I will see you in the future. Okay, we are good times. Bye. Thank you.
Presenza l'idea e facciamo fino a tardi.